and it's my pleasure to introduce our last speaker of the day. Dr. Palejwala is a Phoenix native who completed his high school at Brophy College Prep. He then went on to complete his undergraduate studies at Pennsylvania State University, where he was part of the Phi Beta Kappa Honor Society. He then entered medical school at Jefferson Medical College in Philadelphia, and he developed a passion for ophthalmology and conducted multiple clinical research projects at Wills Eye Institute. He then returned back to the Valley for his internship at St. Joseph's Hospital and Medical Center, and then went on to pursue a residency in ophthalmology at Emory University in Atlanta, Georgia. After completing his residency, he chose to further specialize in vitreoretinal surgery at the Oregon Health and Science University in Portland, Oregon. He joined the Retinal Consultants of Arizona in 2015. And again, I know him from him coming to Havasu and seeing lots of our patients. And he actually gave a presentation on the topic of diabetic retinopathy a long time ago, which I really liked. So I asked him to present on a similar topic today. We all see so many patients with diabetes, so it's so important that we remain aware of all the latest tips and tricks, and you're going to love hearing from him. Welcome, Dr. Palejwala.
Thank you, guys. I appreciate the introduction. Thank you so much for having me. This is an amazing event. I'm just impressed at how widespread it is and how many online people we have. So yeah, please keep the questions coming, and I'll try to keep it kind of quick, and we'll kind of go over some, I think, important. It's easy to get bogged down in numbers and basic science, and I will bore you with some of that, but I do want to kind of keep it clinically relevant too, and kind of say, we're going to talk a lot of research trials that have been done over the years, and kind of how I use them in my practice to help educate my patients and how it affects my treatment decisions. All right, so we're going to talk about diabetic retinopathy, like Dr. Wu said. In terms of what we're going to talk about today, talk about some, like I said, basic epidemiology, pathophysiology, and then kind of go into the meat of things in the terms of clinical definitions, kind of rehash from what we learned in school, and kind of bring some of those definitions back to life, because I know with the advent of imaging and OCT, some of those kind of things that we used to know kind of go out the window. And then talk about treatment and research. So, as everyone probably knows this to be true, but diabetes is only going to get worse in our country, in our world, and the amount of diabetes is just kind of exponentially blowing up, and there's a lot of good treatments out there for it, but people are still getting it, and a lot of that has to do with our lifestyle in the US and everything like that, but it's just, and some of those are genetic factors too, but with more diabetes means more diabetic retinopathy, and we can see from this graph that by 2050 we're looking at about 14 million people in the country with diabetic retinopathy, which is a huge number. Some of the kind of the initial studies on epidemiology of diabetic retinopathy that I like to reference are the Wisconsin epidemiological study for DR, and then also the DCCT and the UK PDS trial. And basically what I the main facts that I gleaned from them are, in the Wisconsin study, they looked at what the correlation was, how long you've had diabetes to when you're going to develop retinopathy. And 99% of people after 20 years of having type 1 diabetes go on to develop, have some degree of diabetic retinopathy. And then 60% of patients with type 2 diabetes after 20 years will have some degree of retinopathy. And I think that's important in educating our patients, especially those ones that they're coming to see you for like just annual screening, and you say, oh, they don't have anything. And then one day you say, oh, well, I think you have something now. And they're like, oh, my sugars are great. What do you mean I have something? They said I didn't have anything last year. And it's like, well, unfortunately, even though you have good control, time always catches up to us. And it's not necessarily what you ate yesterday that caused your NPDR today. It's just years of having the disease. And I think they need to hear that, because I think it is pretty dejecting to think like, I'm doing everything I can and I'm coming in, you're saying I have something wrong with me, and you want them to be motivated to improve their care, not just feel like a failure and then kind of give up on their diabetic control. And then in the DCCT study, they looked at patients with type 1 and type 2 diabetes and with strict sugar control. So like an A1C less than 6, which is probably lower than most of our A1Cs right now after lunch. And the risk of developing diabetic retinopathy was reduced by 75% in these patients with good sugar control. And then the risk of progression was decreased by 50%. So there is something that they can do, even though you're seeing them and you're saying, well, come back and see me in 6 months, come back and see me in 6 months. And they're like, well, why do I keep seeing you? You're not actually helping me do anything. And you say, you let them know that, if the things that you're going to do now are not necessarily take, this and that and the other, but you just want to make sure that your sugar control is good, because that can help, slow down this whole process. In terms of pathophysiology, what happens? So you get, diabetes is a disease of high sugar. We all know that. So high blood sugar, it means more glucose in your bloodstream that gets absorbed by your cells. That turns into sorbitol and fructose. Sorbitol and fructose kind of create this osmotic shift within your cells, and you get osmotic damage and the cells kind of break down. Also, this kind of whole pathway, again, without boring too much with the basic science, NPDH is important coenzyme for helping our body fight oxidative damage. And if we deplete it all by having this pathway going on, overdrive, you lose NPDH, meaning you're at higher risk of oxidative damage. Your retinal capillary basement membrane thickens, your blood retina barrier breaks down. Essentially, you kind of have just breakdown of your microvasculature. All that causes inflammation in our system. High inflammation means there's a higher intraocular blood pressure. When you have weak blood vessels, higher pressure, that's a plumbing disaster waiting to happen. And then you get capillary leakage and occlusion from that. And then we all know VEGF is a huge factor in all of this, right? So what happens when capillaries get damaged, you get higher levels of VEGF in your system. VEGF causes all these things here. Well, it promotes angiogenesis, break down the blood retina barrier, causes endothelial growth, neovascularization, vascular permeability. Bottom line is this, and I think this is kind of to summarize all those other slides. High sugar over time leads to endothelial cell damage, loss of pericytes, basement membrane thickening, and then what that means clinically is you get capillary occlusion, non-perfusion, and leakage. This is a fluorescein angiogram, and I think it kind of represents all those things very well. This is probably a patient with severe NPDR or at least maybe even early PDR or low risk PDR. And what you see here is you get this dark areas here. That's macular ischemia. They're not getting circulation in those areas, so it kind of gets dark, and you kind of see pockets of that right here too. You get tortuous kind of blood vessels that are kind of the vessel walls are staining. You get some leakage right here, so you got leaky blood vessels there, and you can see all these kind of vascular changes that are often common with hypertension. So you kind of see some AV nicking right over here, and so this person's clearly it doesn't have a healthy eye. Okay, going to the clinical definition. So in 1968, they created this kind of classification of diabetic retinopathy that had 13 levels to it, which obviously is way too complex for modern day. And then in 2003, they kind of dumbed that down to 5 stages. And that's what we go off of right now, right? So nothing, mild, moderate, severe NPDR, and then PDR. And then PDR can be broken down into low risk and high risk PDR, which we'll talk about in a few minutes. So the no diabetic retinopathy is pretty obvious. You don't see anything, it's no diabetic retinopathy. The mild to moderate is kind of more subjective, and my moderate might be your mild or vice versa. And that those definite, I mean, they matter a little bit because, the mild ones you tend to bring back like in 9 months, and the moderate ones you bring back in 6 months. So there is a little bit right there that that matters. But really, I think when it matters is that we want my severe NPDR to be the same as your severe NPDR, because those are the ones that kind of matter. And so the 4-2-1 rule is an important rule that I go off, that it's a kind of an easy way to remember it. So 4 quadrants of Doppler hemorrhages, and that's kind of what I know it might not project perfectly, but you can kind of see what that looks like. And you don't actually have to have a whole lot of hemorrhage. I think that's kind of the point I want to come across. If they have a few Doppler hemorrhages everywhere and you're like, oh, that kind of looks mild, but actually if they have that everywhere, that actually could qualify as severe NPDR. Venous beading. So venous beading is when you kind of get your veins have this kind of sausagey kind of appearance to them. I think I have oh, there we go. Okay. And then lastly, one quadrant of Irma, and Irma kind of looks like flat neovascularization. So if you have one of these three things, you qualify as severe NPDR, and severe NPDR means that your risk of converting to high risk PDR within 1 year is about 15%. And I think that's why this matters. And if you have two of the three, then your risk is actually much higher, 45% of converting to high risk PDR. So I think identifying severe NPDR is one of the most important things in screening for diabetic retinopathy. Then we go high risk PDR. What's that? Well, high risk PDR, a little bit of a complicated definition, but I'll try to kind of break it down. So you have two places that have neovascularization. You have the disc and you have everywhere else but the disc, right? So in terms of the disc, if you have less than a quarter disc area of neovascularization with associated vitreous hemorrhage, then you have PDR, meaning if you have less than a quarter but no vitreous hemorrhage, then you're low risk PDR. If you have more than a quarter of disc neovascularization, then it doesn't matter if you have hemorrhage or not, that qualifies as high risk PDR. And then if you have greater than half a disc area of neovascularization somewhere else and vitreous hemorrhage, then you have high risk PDR, meaning if you have, if you have some NV somewhere out in the periphery, but no hemorrhage, then that technically is low risk PDR. Now, some of this might be semantics because sometimes, if it's PDR and you just treat it, or if, you take a lot of other things into consideration, right? So if you have someone who hasn't seen a doctor in 20 years and they're coming in for the first time, you don't want to be like, oh, well, you're fine, come back again in another 20 years. You want to, and those types of people that they're not going to be good follow-up, they're flight risk, you want to kind of do everything you can for them as soon as possible, or at least kind of get them started on treatment, because if you're treating them, then they might take it more seriously than if you said you're fine. So you might, even though technically speaking, high risk PDR is who you want to treat, you may see a lot of retina specialists still treating low risk PDR because of kind of the other issues surrounding the diagnosis. So Optos and wide field angiography, just like Optos cameras have kind of really helped in basic screening. It's really helped our diagnosis of diabetic retinopathy, PDR and PDR, and also in monitoring progression and also monitoring response to treatment. So it's really revolutionized the way we treat patients, but also I think it's really it has added value as a patient, kind of a patient tool where they can actually see it and they can understand it. And it's not, obviously this is something that they can't just look at and say, tell there's a problem, but if you explain it to them, I think they can really appreciate what the issues are. So here's a good example of a PDR patient where you can see that they have significant non-perfusion in the periphery where all these blood vessels just essentially end. Then you can see that they have kind of diffuse macular leakage, and then you get kind of all these kind of lesions of bright, which are neovascularization, and they have neovascularization of the disc right here and multiple areas of neovascularization out here in the periphery. So obviously this is someone where you definitely want to get PRP in, as soon as you can. So what causes people with diabetic retinopathy to lose vision? So there's four kind of big things, the most common being macular edema. And then there's macular ischemia, vitreous hemorrhage, and then also retinal detachment, so tractional retinal detachments. So CSME is a term we all learn in school. And then again, like I was kind of alluding to with OCT, that kind of almost gets forgotten about because you can so easily see it on OCT that you don't necessarily need to be sitting there measuring, 500 microns from the macula and all that stuff. But just to rehash, retinal edema within 500 microns of the foveal center, hard exudates within 500 microns of the foveal center with adjacent retinal thickening, or if they have one disc area of retinal thickening within one disc diameter of the foveal center. So it doesn't have to necessarily be, if there's a large enough area of edema, it doesn't necessarily have to be subfoveal to be considered CSME. Macular ischemia is caused by capillary non-perfusion. So a good way, the best way to see that is actually on fluorescein angiography. And sometimes you'll probably get these patients who's, their fundus, they have, vascular narrowing and you see some diabetic changes. They don't have kind of frank edema on their OCT, but they are, 20/60 and they're pseudophakic and you can't really refract them better. And wondering what's going on, there's a good chance they probably have ischemia in their macula that's kind of limiting their vision. And a good kind of reference points are optic nerve heads. So if they're foveal avascular zone, which is the central area, so that should normally be like 500 microns, less than 500 microns, so like less than 1/3 the size of the optic nerve. And if you see this kind of big area here that's greater than 1,000 microns or greater than 1,500 microns, which is essentially the size of the optic nerve, then that's considered macular ischemia. Vitreous hemorrhage is a common thing that you guys see, and a common things that time when patients are often referred to us, and common times when they realize something's going on, right? So vitreous hemorrhage is caused by a couple things. Number one can be just uncontrolled diabetic retinopathy, where they have neovascular vessels that are leaking and bleeding. But you can also get it in someone who's reasonably controlled. They've had PRP before, they've been okay. And you're wondering, well, why did they bleed all of a sudden? And what can happen is as they get older and their vitreous starts to separate from the retinal surface, they're starting to get a PVD. You get these areas of old neovascularization where the vitreous gel is just extra stuck to the retinal surface, and oftentimes you get pulling at that junction, and it pulls on those weakened blood vessels. So they might not have active uncontrolled PDR, they might be very controlled, but when the vitreous kind of pulls away, that we call that kind of a tractional cause of their vitreous hemorrhage, as opposed to, uncontrolled diabetes. And I think that's important to know, because again, it's important to let the patient know, it's like, hey, it's not because you did something wrong, this is just kind of the evolution of the disease. And then again, TRDs are, kind of the bane of our surgical existence, because they are often very challenging to treat. They're one of the more complex surgeries that we do as retina specialists. And then a lot of that is because you're dealing with weak tissue, you're dealing with weak blood vessels that tend to bleed a lot. And then you're essentially having to kind of tease away this fibrotic tissue off the retinal surface, which can often be quite challenging. So we really want to avoid seeing patients at this stage. So what can we do now? So first we'll talk about the most common thing is diabetic macular edema. So according to the ETDRS study, which kind of set the definition of CSME, 1/3 of patients with and the reason why CSME became a term is 1/3 of patients with CSME will lose, I'm sorry, what was I going to say? 1/3 of patients with CSME will lose greater than 3 lines of vision within 3 years if untreated. And so that's why the CSME became a definition, is that was kind of a benchmark of hey, these are the people we want to treat. And then our treatment options: laser, anti-VEGF, steroid, and in some cases surgery. And we'll kind of talk about each of these one by one. So focal laser is one of the original treatments of diabetic macular edema, and really kind of has lost a lot of, use because of the drugs, like the anti-VEGF drugs and the steroids. But there's still, some cases that are really good candidates for focal laser. And what they found in the ETDRS study, it was that if you do focal laser on someone with CSME, you reduce their chances of getting that severe vision loss by 50%. And so that's how focal laser became adopted. Now, there's two kind of ways we do focal laser. One is, you see all those microaneurysms, and then you try to laser the microaneurysms to kind of occlude the microaneurysms, so that way it doesn't leak from there. Another thing that you could do is kind of what's called grid laser, where you kind of just do kind of just a pattern of laser across a certain part of the macula. And that kind of helps stimulate the RPE cells, kind of excites them to start absorbing some of that edema, so that it kind of helps dry up the macula that way. Now, there's risks of focal laser. So a few things that we know are that, one, you can't focal laser everything. So you don't want to focal something that's too close to the fovea. Otherwise, you have a risk of creating a scotoma in their vision. Number two is that there's something called laser creep. So if you've seen patients where you look at their macula and there's like these giant laser scars throughout their macula, like, oh, who did that? And probably, they got that done like 10, 20 years ago, and those scars were just pinpoint laser scars. And over the years, those laser scars expanded into these larger scars. So, if you have a young person and they have like 50 more years to live, you have to think about that. And then lastly, you can get, if you do a hot laser, meaning you had it on the power on too high, you can actually break through Brooks membrane with your laser, and that laser scar can become a nidus for CNV, where you can get choroidal vessels that grow through that break in Brooks membrane and create another problem. So then we talk about our drugs. So we have intravitreal bevacizumab or Avastin, and that's probably the most commonly used medication for the treatment of diabetic macular edema, often because of its price point and also kind of insurance step therapies and things like that, where it's often kind of from an insurance perspective, it's kind of what they want to be first line treatment for this condition, and other ones that we won't talk about today. But I use a lot of Avastin. It's the most commonly used drug in my clinic by far. And there's a lot of studies looking at bevacizumab, but two that I just want to mention are the Protocol H and the Bolt trial. Basically, both of them looked at focal laser versus various doses of Avastin, and what they found was there was about a 4 times higher vision gains in the Avastin arm versus the focal laser arm. So clearly, bevacizumab for most patients does much better than having to do focal laser. And then, sorry, one thing I forgot to mention, which kind of is important later, but bevacizumab is a monoclonal full-length antibody, so it's the whole big antibody, and that binds all isoforms of VEGF-A. Ranibizumab is essentially, or Lucentis is a cleaved portion of the FAB fragment of bevacizumab. So it's does the same thing. It binds VEGF-A, but it has a much higher affinity because it's a smaller molecule. Again, there's a lot of studies out there. The ones I'm going to reference later in this presentation are Protocol I and also the Read and Rise and Ride study. And basically, again, without getting into all these numbers, basically what they said, what they looked at was they did focal laser versus ranibizumab versus, in some of these trials, versus steroid or triamcinolone. And what they found was that the ranibizumab groups in all 3 of these trials did significantly better. The Rise and Ride study was the 2 parallel phase 3 studies that were the FDA registration studies for ranibizumab. So that's why that's important. And then I'll kind of go over later, some important things I gleaned from that study. Aflibercept or Eylea, again, same thing. Da Vinci was the phase 2 study. Vista Vivid were the phase 3 studies. They compared focal laser versus aflibercept versus steroid in some cases. And basically what they found was that the aflibercept arm, again, surpassed focal laser. So I think in some cases focal laser would be the preferred treatment, but I think in most cases, I think most retina specialists would agree that anti-VEGF just outperforms focal laser. So we talked about 3 different drugs here. Okay, so they're all good in their own. How do they compare to each other? Is one better than the other? That's the obvious next question, right? So that's what Protocol T of the DRCR network looked at, and they compared bevacizumab to ranibizumab to aflibercept. And what they found, and I think this is kind of important data, was at the 1-year mark, if you look at the people that are 20/40 or better, all 3 of these drugs did roughly about the same, right? There was, pretty much equality between them. If you look at the subset that were 20/50 or worse, well, aflibercept actually outperformed the bevacizumab and ranibizumab. And that became a big deal and a big talking point, especially for some of the drug companies. And that's what that kind of shows. The p-value is less than 0.05. However, if you look at the 2-year data, there was some regression to the mean where, there was still, a good amount of separation, but the p-values became less significant. And so the thought was, well, aflibercept still, by absolute numbers still outperformed, but the p-value between this 18.1 and 16.1 was above 0.05, so no longer became statistically significant. So some of those initial, that separation there was some regression at the year 2 data. So our newest player on the market is faricimab or Vabysmo, and that was actually FDA approved, I believe, like last February. So we've been using it for about a year now, and I think last time I spoke with some of the people from Genentech, there was over like a couple 100,000 injections done in the U.S. So we have pretty good comfort and data with this new medication. But it's exciting to have a new medication because prior to that, aflibercept was the newest, and that was 2011. So we haven't had anything in over a decade. So Yosemite and Rhine were the phase 3 studies, and what they compared aflibercept to this faricimab. And faricimab is different, a little bit different in that it's a bispecific molecule. So we've always been talking about so far is VEGF, right? And this one, so if you remember from kind of basic science, an antibody kind of looks like a Y, right? There's two arms that actually bind to proteins and stuff like that. So in Avastin, both those arms are anti-VEGF. In faricimab, one of those arms is anti-VEGF, and the other arm is this thing called anti-angiopoietin 2. And angiopoietin 2, again, without getting overly detailed, angiopoietin 2 is another player within this vascular leakage kind of cascade. And so the thought is, well, if we can target both of these instead of just one of these, we might get better effect, better vascular stabilization, and better outcomes, more durability of effect, and so forth. So that's how it kind of differs. So basically, in this graph, what you can see is that aflibercept versus faricimab, well, all these curves look about the same. So faricimab was non-inferior to aflibercept in terms of visual acuity. What this looks at is what they did in the trial was they started to do what we call treat and extend, where, if they did well at 4 weeks, then they pushed them out to 8 weeks, and then they pushed them out to 12 weeks, and they pushed them out to 16 weeks. And what they found was that in the faricimab arm, about 70% of people were able to go to Q 12 to 16 weeks. So they were able to get shots every 3 to 4 months, as opposed to having to do it monthly or every other month. So we see a good durability of effect. And I kind of see that in my patients. Some of my patients who were on other medications that I switched them over to faricimab, I have been able to see that I've been able to go out further between shots. The other thing that they noted that was statistically significant was that the percentage of patients without edema. So the purple is the faricimab arms, and this is the aflibercept arm. And so you can see that there was a higher percentage of people at both of these time points that were dry on their OCT. So I think I've said a lot of numbers and kind of talked about all these drugs. I think these next couple slides, I think, are what I think is the most important when we talk about anti-VEGF. And these are what I kind of reference to when I talk to my patients and counsel my patients. So firstly, this is from Protocol I, and what this graph kind of shows is what happens at 5 years. So, that's what patients always say. How long am I gonna have to do this? Am I gonna be blind in 5 years from now? What's gonna happen in the future, right? And this kind of tells us that, hey, when you start doing injections, you get this great uptick in vision. People start seeing better pretty quickly, and then that result is maintained. Now, that's not true for everybody, but, on average, that's a pretty good curve, and that's a pretty good, maintenance of vision here, where, they're not, whereas if you look at the AMD graphs, they go up and then they slowly kind of go down. So at least it's, a better outcome than our macular degeneration patients. Now, Rise and Ride, right? That was the phase 3 study for ranibizumab. And I think what I get out of this trial, and I know it's kind of probably hard to see here. So what they did in this study is they had 2 groups, or 3 groups actually. They had 2 different doses of ranibizumab versus sham, which is they didn't get any treatment. And in the ranibizumab arm, which is the top curve, you can see that they got better, right? Their vision improved. The sham, you would expect they didn't get better, they didn't get worse, they stayed the same. And that's right here, right? And they did monthly injections for 2 years. And at 2 years, there was a significant amount of people in the ranibizumab group that were better than in the control group. However, at the 2-year mark, they started doing a crossover where the control arm could start getting ranibizumab injections. And then they started getting a little bit better, but they never caught up to where the people that were getting treatment all along. So that tells me that if the longer treatment is delayed in these patients, yeah, they may still get better later, but they're never going to be as good as they could have been if they started treatment right away. So time is kind of also of the essence in the treatment of DME. You can't just sit on it for a long time and then start treating it. And then lastly, I think, and this is I think what patients want to know, right? How often am I going to have to get shots? How many shots am I going to get? Does it ever get better? Is this going to be every month for the rest of my life? Right? And some of those people, yeah, it is every month forever. But in most people, I tell people that this is like a 5-year type of kind of treatment plan, in the sense where, in the first year, we have to do a lot of shots. And then every subsequent year, it kind of goes down. And by the 5th year, about more than 50% are getting 1 or fewer shots. So, there is a light at the end of the tunnel, so to speak, and that it's not going to be, it helps people buy into it, like, hey, stick with it now, come every month. I know it's hard. I know it's not, you have a million other things to do, but this is really important and this is going to pay dividends later. You're going to be able to maintain vision. You're not going to have to do this forever. You're going to, and it really helps kind of create that commitment where they can really buy into your treatment plan. So every patient, everything we've talked about so far has been looking at people with 20, 40 or worse vision. That's what all those research studies included. What about especially with OCT, now we can see more, right? So what do we do with it? When we can see more, now we have to figure out what to do with those people, right? So what do you do with the 20-25 person who has a little bit of edema and they're asymptomatic and you're like, oh, I wasn't expecting to see that? Well, that's why we have a study about that. So that's great. So now we kind of have an answer. So this was protocol V from the DRCR network. And what they looked at was in the 20-25 or better patients, looking at aflibercept versus focal laser versus doing nothing and maybe doing aflibercept down the road if they get worse. And what they found was that if you look at all this at 2 years, everyone did about the same. So what that tells me is that in those people with really good vision, I'm okay watching it. And I don't have to get all excited. I don't have to start injecting them right away. I can wait. And if they get worse, I can see. And what I typically do is I see them about every 3 months. And if they get worse, then we worry about injections. Because and this study kind of validates that, because then when you look back at the other slide I show you, well, if we sit on it, maybe we won't get the vision that we would have gotten. I think that applies more so to the people that are a little bit worse off. But the people that are mild, I think we're okay to watch. Now switching gears a little bit to steroids. So there's 3 kind of steroids that we'll talk about here. So triamcinolone, which was is kind of one of the older treatments that we do that still is very effective, but there's other steroids that we'll talk about. But essentially, steroids work. They 26% gained about more than 15 letters, but they have their own risks. Intraocular pressure and cataract being the 2 biggest ones, right? So in this study, 12% of people needed IOP meds. 84% of people developed cataracts. So cataracts and maybe glaucoma kind of go hand in hand with steroids. Next, we have the intravitreal dexamethasone implant, which is a brand name Ozurdex. And that's a slow release. It's an injectable that is slow release. And, you get about 3 to 6 months out of it. And again, same thing, helped vision, also caused cataract, also caused pressure problems. Lastly, we have intravitreal fluocinolone, which goes by the brand name Iluvien. And this one's kind of cool because it actually, whereas everything, anti-VEGF is kind of like monthly to maybe quarterly, Ozurdex is like 3 to 6 month-ish. This is kind of on the span of multiple years of efficacy out of one injection. So you can get up to about 3 years. And I've yet to see someone in my patients that get the full 3 years, but you get into the multiple year category, which is amazing compared to everything else. Again, same thing. Nearly all the phakic ones got cataract, and then the risk of incisional glaucoma surgery was somewhere between 5 and 8%, depending on the dosage it was. So not without risk. Okay, so just to recap, advantages of anti-VEGF, lower risk of glaucoma, cataract, advantages of corticosteroids. It can be more effective in those chronic DME cases where they have more of an inflammatory component. Also, it can be administered via a sustained release device that can last for several months or years. So when do you know, like, who to put on steroids, who to do anti-VEGF, right? You know, that's the obvious next question. And what the data I use to answer that question for myself is from this protocol I post hoc analysis. And what they did was they looked at people after 3 months of injections, and they stratified them into 3 groups. So people that gained a lot of vision, people that gained a little bit of vision, and people that gained 0 to no vision. And they looked, and those people are right here, and they looked at them again in 3 years. And this is just getting anti-VEGF. And so you can see that they kind of stay in their lane, meaning if they didn't do that well after 3 months of injections, they didn't do that well after 3 years of injections. And if they did really well after 3 months of injections, they did really well after 3 years of injections. So 3 months is a good barometer of where they're going to be. And so that's kind of what I do. I tell patients, we're going to do 3 monthly injections. I'm not even gonna. I don't even get an OCT when I see them for those 3 months. I just do the injections because I'm not going to do something different with that information. Now, obviously, if something got worse or something changed, then you want to look at them again and all that stuff. But if everything is doing okay, then I usually don't even do any imaging or anything like that until 3 months. And that 3 months, I kind of see which lane they fall in, and that kind of helps me say, well, maybe on this one I'll probably try something different sooner, because if we do the same thing, it's probably not going to be any better. So quick, and briefly we'll talk about PDR and NPDR. So proliferative diabetic retinopathy we know PRP, and that was first came about in the 1950s. And the idea of PRP came back that when you look at people who have like severe myopic degeneration or retinal degeneration, like retinitis pigmentosa and stuff like that, they tend to, actually not have that much diabetic complications. And the thought is, well, maybe all that scarring kind of helps them. And so why PRP works is that, we think peripheral ischemia of the retina that can release vascular growth factors that can cause neovascularization. If you laser that area, that might kind of stimulate the retinal cells to produce kind of this inhibitory factors. And then laser scars kind of can thin the retina. And by thinning the retina, you might increase kind of diffusion of oxygen from the choroid into the retina. In 1970s, we had the DRS study, the diabetic retinopathy study, which essentially took a patient with advanced diabetic eye disease, and they did PRP in one eye, and they did nothing in the other eye, and they looked at how they did over 2 years. And what they found was that 15% of people who you did nothing to, they had advanced vision loss, whereas only 6% of people who you treated had advanced vision loss. And so they actually ended the study early and said, hey, we should do PRP. But PRP is not perfect, right? You're ablating the peripheral retina. And what does that cause? Well, that causes you would think that would cause reduction in their peripheral vision. It actually also reduces their contrast sensitivity. It reduces their night vision. And a lot of patients do complain about that after they get PRP. And then lastly, it can also make diabetic macular edema worse. And so if you have someone with both proliferative diabetic retinopathy and DME, I often treat the DME component first with injections and get that stabilized before I would consider doing PRP. So the next question is, well, anti-VEGF is great for everything so far. Why wouldn't it be good for PDR as well? And that's what Protocol S tried to answer. And so they compared people getting regular treatments with ranibizumab versus PRP laser. And what they found, and they kind of split these people into 2 groups. PDR with DME and PDR without DME. And just like we talked about, we kind of expected these results, right? The patients in the DME group, well, they did much better with ranibizumab versus just PRP alone. And then people without baseline DME, well, the ranibizumab group just still did a little bit better, but it was less, the difference was less significant. I thought this was interesting just because, you think you treat something, you make it better, it goes away, right? And in both of these arms, so this is what, if you did they take the ranibizumab group and the PRP group and then looked at them after 2 years of being in the study, still a good amount of them still had active NV, 40% even, right? So you would think, well, we treated them really aggressively and they still have active neovascularization. So that just tells you that even in these eyes that get PRP and they look quiet, it's something that you still got to watch for the rest of their life because they can always develop a problem. And then at 2 years in the study, I thought this was also interesting, is that the risk of complications like NVG or vitreous hemorrhage in the ranibizumab group and PRP group, none of that was statistically significant, meaning they had the same amount of complications, except for needing vitrectomy surgery. So a significant amount of more people in the PRP alone group needed vitrectomy surgery. And I think that's because of how both these modalities work. When you give anti-VEGF, like if you've seen someone with, say, like iris neovascularization, you give them anti-VEGF and you see them back a couple of days later, all that iris neovascularization is gone. Like it works really quickly. PRP, not so much. PRP kind of has a more slow effect. And so I think what happens is when you make neovascularization go away immediately, it doesn't cause some of the collateral damage that if it goes away slowly, because when it goes away slowly, you can get fibrosis and you can get these fibrovascular membranes. You probably see those along the vascular arcades or along the optic nerve head, and you're less likely to get that with anti-VEGF treated eyes. And that is kind of the nidus for, like we talked about, for tractional detachments and pulling and epiretinal membranes and stuff like that. And so that's why I think the anti-VEGF eyes get need less vitrectomy. So again, just to recap, advantages of the PRP: it's more permanent. If you're only going to see someone one time, you want to PRP them because you never have to do it again. As a permanent effect, it's lower cost to the system, right? All these drugs are very expensive, as Barakat kind of alluded to. No risk of endophthalmitis, which comes with injections, and no risk of that theoretical risk of systemic exposure from anti-VEGF medications. Advantages of anti-VEGF are, less of the PRP complications, peripheral vision, contrast sensitivity, all that stuff, less chance of vitrectomy, and then it's better when you already less risk of DME or worsening of your DME. Okay, last topic, I promise. What about NPDR without DME? I think that's the only thing we haven't talked about. So the Panorama study looked at patients who got nothing and they got aflibercept when they had just NPDR, meaning no proliferative disease, no DME, just NPDR. And what they found was that in the eyes that got sham versus these two dosing of aflibercept, there was a significantly higher amount of people in the aflibercept arm that had a 2-step or more reduction in their diabetic retinopathy severity score. So giving an NPDR patient with anti-VEGF will make their NPDR better. And then I thought this was the protocol W was another similar study looking at and treating NPDR. I thought this was interesting. They looked at time to develop PDR, DME, or diabetic complications, and they found that if in the arm that got aflibercept regularly, they had at 2 years about 16% of them developed PDR or DME, whereas 44% of people with NPDR developed PDR or DME after 2 years. So definitely there is a role there is a signal that giving anti-VEGF to NPDR helps. Are you going to do it to everyone? I can't fathom doing it to everyone. We saw that first slide. There's like 14 million people out there with diabetic retinopathy. Are we going to give them all injections? That I think that would instantly, stall our clinics. We'd have to work 24/7, right? And it's just not that. It's the treatment burden, right? You have a 40-year-old who's working, has 2 young kids. How are you they have to go to their endocrinologist, they have to go to their foot doctor, they have to go to their kidney doctor, and now you're telling them they need to get injections every month with you. It's just not feasible. There's always risks of doing injections. There's a 1 in a few thousand risk of getting, endophthalmitis, but it adds up, right? And so I don't necessarily do any of that. The people that I use this data to kind of help me with are the ones who have advanced vision loss in one eye. They're monocular. They had, bad TRD in one eye. They already bled before multiple times in that one eye. They had MVG or whatever in one eye, and the other eye has severe NPDR. I may be more inclined to inject that person with anti-VEGF before they develop any of these bad things, as a more of a prophylactic or preventative treatment. But I'm not going to take your average person with moderate NPDR and start injecting them. And there's some retina specialists that do, and I mean they're going by the data, and that's fine. But I just personally, from a cost benefit standpoint, I just think that as long as you can maintain good follow up with them, and watch them over time, I don't think you necessarily have to do that. That was my last slide. Any questions?
Any in-person questions? Okay, few that have come in online. Have you found anything that helps patients change their behavior and take diabetes seriously? I find that no matter how much I show them photos and educate them on what will happen, many patients refuse to change their lifestyle, diet, or exercise.
Yeah, that's a hard one. And I think oftentimes that falls, retina specialists, we're very busy with all these injections. And as you saw what Bearcat talked about with dry AMD, if we're going to start injecting those patients, the amount of volume we see is just incredible. And so the amount of time we get per patient becomes slowly less and less. And so it's difficult for us to have a lot of those conversations. And that's why I say sometimes the ownership of that often falls on you guys, and unfairly. But it's hard. I think the best thing in my opinion that I've done is with imaging and just kind of explaining it in a layman's terms, and having the fluorescein, having OCT. I mean, I don't think it takes a rocket scientist to kind of be able to tell a bad OCT from a good OCT. There's nuances that obviously, the reasons why we go to school for, but otherwise, I think basic things we can kind of explain to our patients, and then it kind of becomes a game, right? Like you show the patient, like, oh, well, you got injection, you were getting injections every 6 weeks or 8 weeks or whatever it is, and like, look how good you are. And then they get sick or something happens, or they come back 3 months later, or they want a vacation, or whatever, and they come back and they're worse, and you can show that to them, and they can get it. And even if they don't necessarily notice it in their vision, or they're not having, the visual complaints, they can appreciate swollen versus not swollen. And I think you just have to engage them in every visit, and that's easier said than done, right? Because in a busy clinic, you kind of want to do whatever it takes to kind of get things taken care of efficiently. But sometimes spending that extra time kind of explain the imaging, in my opinion, I think that's where we can kind of, both the patient and the doctor can kind of understand what's going on, and can kind of be on this even playing field.
Yeah, I think it's just a hard thing. I know we all deal with that. So it's that is a tough question. Why was the aflibercept superior in the 20/50 or worse category?
That's a good question. And I think, what the thought was, it's what the company wants you to say is, well, it's a better drug, right? But I think aflibercept definitely has it works a little bit differently than ranibizumab and bevacizumab. It's a kind of a VEGF trap molecule. So it's this larger molecule that kind of sequesters VEGF as opposed to kind of blocking the receptor, as the other ones do. In terms of the exact why, specifically for the 20/50 or worse, I think, I don't know. I mean, the thing is, there's a ceiling effect, right? When you have the better vision you have, the less room for improvement you have. So it's harder to tell things in people who have, it's harder to find statistically significant findings in people who are 20/25 or 20/30, because they have less room. They physically have less room for improvement. You can only get so good. Whereas in the people with the worst vision eyes, they have more room for improvement. And so sometimes you can kind of see those differences. So I think that's probably why you're seeing it. I don't think that like aflibercept is specifically a drug that you should reserve for 20/50 or worse, and if 20/40 or better, it's not as effective, or there's something different about the 20/50 versus the 20/40 eyes. I think it's just that you're going to see more improvement because there's more potential for improvement.
Great. Are most anti-VEGF drugs covered by insurance?
Great question. So Medicare covers all anti-VEGF drugs, and pretty much all insurances will, with the right steps in place. So often you need to get prior authorizations There's this thing that you might have heard of as step therapy, where patients are often, even though we have all this data, right? And you say, well, you might say, well, I sent my 20/70 person to you and you said aflibercept is better. Why are you treating them with bevacizumab? And the reason is often our hands are tied because of insurance, and insurance often says, well, you need to start with bevacizumab because there's actually a good chance that bevacizumab will help that person. And if it doesn't help them, yeah, then you can tell us it didn't help them, and then you can switch it to something else. So there's a cost, barrier within medicine that we have to kind of deal with. And so, but yeah, no, to kind of long story short, yeah, insurance companies do recognize all these treatments and they do pay for all these treatments with encouragement.
Great. And last question, can you discuss the pathophysiology of TRDs? I encounter these frequently in my low vision practice, and when I refer to the retinal specialist, it's often noted that these are inoperable.
So a TRD, so the reason why that happens is you get neovascular. So I want you to think of this in 3 layers. So you have your retina, and then you have this, what we call the vitreoretinal interface, which is the junction between your retina and your vitreous. And then you have the vitreous gel. So neovascularization, by definition, doesn't grow inside the retina. That's IRMA. So IRMA grows inside the retina. Neovascularization grows at the vitreoretinal interface. So it grows in that potential space between your retina and your vitreous. So when you get neovascularization there, if it sits there long enough, you'll get fibrosis with that neovascularization. So that's when you see that white tissue on your retinal surface. And that creates an adhesion between your vitreous gel and your retina. And so when it's just when that neovascularization, even if it's fibrotic, when it's just sitting on the surface of the retina and not doing anything, it actually is not causing any type of problem. So just because you see that fibrotic tissue doesn't mean they have a TRD, doesn't mean they need surgery or anything like that. However, when that vitreous gel starts to pull away, when they start turning 40, 50, 60, 70, however, whatever age that vitreous gel starts to liquefy and starts to pull away, when it pulls away is when you have that adhesion point. So it's pulling it because of that fibrotic tissue, it's pulling the retina with it. And that's what creates a TRD. So when we go in surgically, what we have to do is we remove the vitreous, but then we have to go in that vitreoretinal interface and release the traction off the retina. So sometimes that means we can peel that fibrovascular membrane off the retinal surface. And sometimes that means we just have to cut around the vitreous that's attaching to the fibrovascular membrane, because the retina is so thin and brittle that if we pull on the retina, we might cause bleeding or tearing of the retina. The cases that are deemed inoperable, so there's 2 reasons why something is inoperable, right? There's something that's truly inoperable. It's like, there's nothing I can do to make this situation better. And the retinal detachment's so bad, that there's so much scar tissue that I'm going to go in there and make things worse. So that can be inoperable in that sense. And it can be inoperable in that I could go in there and make it better, and it could physically look better, but the patient's not going to see any better. And so then at that point, what's the point of doing it in the first place, right? So I would say, in my personal experience in TRDs, I get, a small percentage are what we call inoperable. I think maybe you might have a little bit of a selection bias in a low vision clinic, where those people are there because they have extremely poor vision and they've had extremely poor vision for a long time. That in that situation, maybe the benefit of operating just isn't there.
Great. Well, thanks, Dr. Palejwala, for a wonderful presentation and a great way to end our posterior segment innovations event.
Awesome.
Thanks so much.
Thank you so much. I had a great time. Thank you.